Physical therapists are an important part of the healthcare system, providing medically necessary, high quality care to patients. At the same time, PTs and PTAs play an important role in protecting the integrity of the healthcare program so patients can continue to receive the high quality services they need. It's important that PTs, PTAs, students of physical therapy, and physical therapy assistants are knowledgeable about fraud and abuse laws to help prevent any potential fraud and abuse. While the vast majority of healthcare providers are ethical and honest and provide high quality care, fraud and abuse laws are very broad and can have an impact on most providers. During today's presentation, we're going to focus on providing some background on the healthcare fraud problem, explaining the distinction between fraud, abuse, and waste, describing fraud and abuse laws, discussing risk areas involving physical therapy relationships with payers, referral sources, and patients, emphasizing the importance of professionalism and ethics, and explain the best ways to minimize risk of fraud and abuse through compliance programs, as well as how to take action if you've witnessed fraud, abuse, or waste. So let's first talk about the problem. Healthcare fraud, waste, and abuse is a serious problem in the United States. The Justice Department recovers over $4.7 billion from false claim acts in fiscal year 2016. Of that $4.7 billion, $2.5 billion came from the healthcare industry. And that $2.5 billion only reflected the federal losses. In many cases, there's also losses at the state level with the Medicaid programs. 2016 represented the seventh consecutive year where healthcare fraud recoveries exceeded $2 billion. And if you look at the period between 2009 and 2016, the total dollars in healthcare fraud claims that were recovered was $19.3 billion. This fraud, waste, and abuse results in overutilization of services, increased cost for payers, corruption of medical decision-making, unfair competition, and harm to patients. I don't know if any of you recall, but there was a very serious case in Michigan, I would say about a year ago, where there was a huge result in patients. There was a physician over in Michigan that was diagnosing and treating patients for cancer and providing very expensive treatment and billing for that treatment. And in all reality, those patients actually did not have that diagnosis and did not need that treatment. It's probably one of the worst cases I've heard of. Where there has been significant harm to patients with the care that was delivered. Important to note here that the government is going to continue to invest money for programs that fight fraud, waste, and abuse, because for a 3-year period, for every $5 for every $1 the government spent, they had a $5 return. So the return on investment has been very good for the programs that fight healthcare fraud, waste, and abuse. So let's talk about what is fraud. Well, fraud involves obtaining something of value for which you are not entitled through intentional deception or misrepresentation of material facts. That idea is very, very important, of the intentional deception or misrepresentation. So examples of fraud would be knowingly billing for services not furnished, knowingly altering claims to receive more payment, or falsifying documentation to receive payment for which you are not entitled. Let's move on to abuse. Abuse involves payment for items or services for which there is no entitlement. In contrast to fraud, abuse involves instances in which the provider has not intentionally misrepresented facts to obtain payment. Examples would be billing for services that are not medically necessary, billing for services that don't meet professional standards of practice, unbundling services and billing for them, for example, billing separately for electrodes, which are considered part of the payment for electrical stimulation. And then let's finally move on to what is waste. Waste involves incurring unnecessary costs due to deficient management practices, systems, or controls. So examples would be duplication of services that were already provided somewhere else, spending on services that lack evidence of producing better outcomes compared with less alternatives that are less expensive. So we have some major fraud and abuse laws at the federal level that can help us to understand what our roles are and what could potentially be the penalty. There are 5 that are most relevant to physical therapy. They are the False Claims Act, the Federal Anti-Kickback Statute, Physician Self-Referral Exclusion Authority, and then there's the Civil Monetary Penalty Law, but we've tied that in with how we're going to discuss False Claims Act here. So what is the False Claims Act? Well, under the False Claims Act, it's illegal to submit false claims or use a false record to obtain payment from Medicare or Medicaid. Important to note, there is a difference here from what you're going to see in your textbook. There was a recent, I don't know if you want to call it an upgrade or change to this law. And it used to be that for each claim, there could be between a $5,500 and $11,000 penalty per claim, but that's been increased. Now the civil penalty is anywhere from $10,957 to $21,916 per claim. Okay, so that's really important. So if you've got a provider that's, let's say, provided 100 false claims, they're going to have that penalty on each of those 100 claims. Then what they do is they figure out what you actually billed the government and what the damages were, and then they can triple, or you'll hear them say treble, those damages. So you're going to have the penalties on each claim as well as the treble damages for the entire case. So again, a False Claims Act, it's any person who knowingly presents or causes to be presented to the United States a false or fraudulent claim for payment or approval, knowingly makes, uses, or causes to be made or used to the United States a false record or statement material to a false or fraudulent claim. Here, it's really important to understand the terms of knowing and knowingly. That means that a person with respect to the information has actual knowledge of the information, acts in deliberate ignorance of the truth or falsity of the information, or acts in reckless disregard of the truth or falsity of the information, and it requires no proof of a specific intent to fraud. Okay, so what we really want to understand here a little bit is that often we may do some type of an internal investigation or have some type of an internal complaint that occurs, and we are able to self-identify an overpayment. So yes, maybe there was a claim submitted, we identify something was incorrectly billed, an incorrect code was put on, or some other issue. That doesn't necessarily have to go to a false claims litigation or penalty. There is the ability for providers to identify their own issues and report an overpayment. Okay, what's very important is this 60-day report and return rule. This just came about a couple years ago, and what everyone is really sort of struggled with a little bit since this came out is really understanding when the clock starts to count on the 60-day part of it. Okay, so essentially this is a reporting and returning of overpayments. What it says is that in general, if a person has received an overpayment, they need to report and return the overpayment to the Secretary of the State, an intermediary, a carrier or contractor as appropriate at the correct address, and they need to notify them that they are returning this overpayment, and the notification needs to be in writing with a reason. The deadline for reporting and returning the overpayments is at the date, which is 60 days after the date on which the overpayment was identified, or the date any corresponding cost report is due. So you can see there I've got that word identified in red. That's what everybody struggled with. Well, when is the actual identification? When does that clock start to tick? The statute itself does not have the definition of identified, Okay, when you look further into the regulations, they don't have that specific word identified, defined. What it does say is that a person has identified an overpayment when the person has or should have, through the exercise of reasonable diligence, determined that the person has received an overpayment and quantified the amount of the overpayment. A person should have determined that the person receiving the overpayment and quantifying the amount of the overpayment if the person fails to exercise reasonable diligence and the person in fact received an overpayment. Okay, that's a lot of legal jargon. What does it actually mean? Well, what it actually means is they recognize that at the time you get a report, at the time you get an audit, you may not actually know the dollar amount. You may think you have a problem. They are going to give us time to really look into the problem and really be able to quantify it. Once you've got that quantified number, that's when the 60-day overpayment rule comes into play, that you need to return the money and you need to give them a reason why. So there's still a lot of back and forth language, a little bit on that word identified, but I think people are becoming more comfortable with it. Very often, if it's a large situation where you're talking high dollar amounts, we have our legal counsel involved as well when we're going through that function. If it's something small, and we can deal directly with our Medicare administrative contractor, or our MAC, who here in Wisconsin, that would be National Government Services. We've talked about them a couple times. That's much simpler. You know, we can actually do claim corrections if we're within the 1 year timely reporting time frame. So very, very important that you allow compliance to do their piece of the investigation, involve legal counsel as necessary. But I just want everybody to understand they take it very, very seriously. And if you would self-identify and not go through that reporting process, then they could potentially initiate a False Claims Act for you. And that's when the damages become extremely punitive and very high. Now, the other thing that we want to understand a little bit here about the False Claims Act is that there is a piece of it known as a PTAP, okay? Or what you'll hear people talk about sometimes in the news, or if you read something, it's about a whistleblower, okay? So people can bring forth to the government a case that they're aware of, and it goes into a sealed record called a PTAP, and it's kept sealed for quite a while the Department of Justice has to make a decision of what they're going to do. There is strong financial incentive for people to become a whistleblower, or to bring forth a PTAP case. They can receive 15 to 30% of the government's overall recovery. Now, here, what's really, really important to know is this is not for very minor things. This is, here's the other thing I always want to tell people is when you are an employee of a company, you will have a compliance program. Your compliance program within its policies is going to say you need to bring that forth internally. So, that's a very important piece of things. But there is that financial incentive of that for 15 to 30%. Rehab care, if you guys remember that settlement that happened, I think it's about a year or two ago, there was a $125 million settlement. Well, it was brought forth by some whistleblowers that worked at rehab care, so they received nearly $24 million as a share of the recovery. Now, it's not easy to bring a PTAP. You have to come forth with extreme knowledge if the DOJ is going to want to accept that case, and it usually has to be very, very high dollars in order for the DOJ as well to want to touch the case. Unfortunately, healthcare fraud has become a huge industry, and to be honest, you guys, there's organized crime involved in the true fraud cases that happen throughout the United States, where they truly are buying people's Medicare numbers, making up fake records. I mean, a lot of that is a very organized crime situation. They aren't true providers. They are typically not providing true care. So in these cases where you really are providing care and you're doing the best that you can every day, you're not going to see these quite as often, because usually people are trying to do the right thing. But we do have cases here where there have been really large monetary settlements. Now, what I want to let you know is that when you see some of these really large dollar amounts, they are a settlement, okay? That means typically they're not going to say that there truly was a finding of wrongdoing. But unfortunately, to fight some of these cases, if you really feel like you have done nothing wrong, the cost can be prohibitive to actually try and fight it. And typically, they don't recommend that any of these go into a courtroom. To be honest, the recommendation is typically to settle. It's usually, if you make the choice to settle, it's a cost saver to you as a company. Unfortunately, though, sometimes you still hit the headlines. So we've got some, headlines here that had to do with therapy. And this is that Kindred Rehab Care case where they had to pay the $125 million to resolve False Claim Act allegations. And then 4 of the nursing homes that were using their therapy had to pay an additional $8.2 million. There was a very large settlement here. I think this is the biggest one we've seen, the $145 million for Life Care Centers of America, to resolve False Claims Act that was related to the provision of medically unnecessary rehabilitation therapy services. This Extendicare one was really interesting. This was in the news a lot here because at the time, Extendicare had most of their offices out of the Milwaukee area. They had to agree to pay $38 million to settle false claim allegations, but this one was very unique. There was in this particular settlement and in the corporate integrity agreement that came out of the settlement, it was unique in that it had quality of care issues. So there was a lot of unique requirements in the corporate integrity agreement because of the quality issues. So this one is an interesting one to look at. There was a nursing home operator in California that had to pay $48 million to resolve allegations that they billed for unnecessary therapy. New York, $3.5 million, again, concerning claims for therapy. This $3.8 million settlement was involving rehab care as well. And in the settlement, in the language, they literally said, hey, nursing home, you need to really give some oversight to your therapy providers. Same thing in this $1.3 million settlement. Home health as well has been in the news and has been a huge area of concern. This was a big concern when I worked on the government side of things. We often saw where, unfortunately, low income Medicare patients, people that were easier target, maybe patients that maybe English was not their primary language, where they would have trouble interpreting their explanation of benefits. They would be targeted by more of those organized crime type situations where they would go and send recruiters in and get people to actually give over their Medicare number, and then that Medicare number would be sold and used over and over. In home health, that was a very, very big scheme. And the other thing in home health that you'll see is this scheme to go into these major senior apartment buildings. And these people may not necessarily be homebound, but the way that they sort of try to sell their product is an issue. So in this case, Amadeus Home Health had to agree to pay $150 million to resolve false claims. In 2015, there was a group out of Iowa that had a $5.63 million settlement. Detroit Area Home Health Agency and the physical therapist who was helping them to forge the records. This was truly a big fraud scheme of $2.3 million. But this is one of the groups in Detroit where therapy was a huge, huge scheme. It started in outpatient and then it moved into home health, where they were literally just selling the Medicare numbers. And you could follow these Medicare numbers. They would bill really hard at one agency, then stop billing there, and then move on and sell the number to the next. And with that came the medical records that they had people making up. Outpatient Part B therapy is also in the news. One of the biggest one that we started and talked about at the very beginning of the semester was Fox Rehabilitation. It was a $29.9 million settlement. That's saying that the services that they were rendering, which they were doing Part B in the home, did not meet Medicare requirements. In this next case, it was actually a physician who was billing for therapy services. The therapy services were phantom therapy services, meaning that they didn't actually happen, and he had a $900,000 forfeiture and civil damages. And then there was this Norcross Clinic owner. This person actually got prison time. And it was allowed 3 years supervised release, but had to pay a restitution of almost $1.2 million because it was a conspiracy to commit fraud. They were submitting false claims for doctor visits, acupuncture, and physical therapy to Medicare and Blue Cross Blue Shield. In this next fraud scheme, this is another one that involved therapy. And again, it was a true fraud scheme, meaning this was organized. This was true fraud, $28.3 million and a sentence of 11 years in prison. And then this one was actually really sad when we read this report. It was an Illinois physical therapist in private practice, not a large practice, had $634,000 in Medicare reimbursement that what they said was improperly claimed. And you guys, this one really came back to everything we talked about the importance of our documentation. Unfortunately, this therapist documentation just didn't have everything that it needed to have, and part of what they were missing were those certifications. So remember how we talked so important that some of those technical things that we need to do of getting the physician's signature, having the date, having all of our ducks in a row for our 10th treatment day, notes and visits by the clinician. Unfortunately, this was not a case where they didn't provide care. They were providing care. They were providing very good care. They just didn't have everything in place that they needed to in order to be able to bill for that care. So this was a lot of technical issues. This one, you always feel sorry for someone that, did they not know the rules? Well, they should have known the rules, right? All of Medicare's rules are right there on their website, but this is an unfortunate event, especially when you look at that dollar amount. I know that looks like pittance compared to some of the $1 million ones we've talked about here in the previous slides, but for a small private practice, this can be devastating. So with the False Claims Act, typically what will happen with a settlement is you're going to have those financial penalties, okay? If they pursue it also criminally, there could be some jail time, prison time. A lot of what you see, though, is just the civil penalty, and what comes along with that civil penalty. And pretty much every case, I don't think that I've seen a case where this hasn't happened, but they also put the provider under what's called a corporate integrity agreement, okay? This is something that the OIG, the Office of Inspector General, is going to negotiate with the provider, usually the provider's attorney, okay? And what happens with this corporate integrity agreement is it's usually 5 years, okay? And this is the document that's going to say, hey, provider, this is everything for the next 5 years that you are going to be held accountable to, okay? You have to put in a compliance program. If you already have one, you get credit for that, okay? That's gonna really shed a positive light on you, but there are things that they're gonna say, this is what we want that program to look like. They want to see a compliance officer and compliance committee. They want to see your written standards and policies. They want to see a comprehensive training program. Typically what that's been in most of the CIAs is 3 hours of training at hire that's all about compliance, and then annually that training occurs as well. They have to retain what's called an independent review organization. You'll hear it termed an IRO. That's the organization that's going to actually come in and conduct annual audits and reviews with whatever the focus area is, okay, depending on why they ended up under the corporate integrity agreement. So they may be looking at charts. They're going to come on site and look at your processes, look at how you run your meetings, look at your policies, look at the training program. So they're really doing the full audit. You do have to have a confidential disclosure program, meaning there has to be a confidential way for your employees to be able to report a problem. You do have to restrict employment of ineligible persons. We're going to talk about that a little bit later when we talk about exclusions. And you have to report any overpayments, reportable events, ongoing investigations, or legal proceedings. And there is an annual report that has to be generated that goes to the OIG every year for those 5 years. So on your Blackboard, in addition to this PowerPoint, I actually did put 2 links to actual corporate integrity agreements on there. One for the rehab care, and then that would be more inpatient, and then one for Dreyer physical therapy, which was a large settlement that occurred for an outpatient clinic. I highly encourage you to read through those so you can see exactly what the government is looking for when they judge a program. Okay, so this is what they really expect providers to have in place already, except for the IRO piece of things. But like I said, you'll kind of get credit if you ever do potentially have a misstep in the fact that you do have some of those things already in place. But this is really kind of a step-by-step of what should a compliance program look like. So let's move out of false claims and look at anti-kickback. The government's very concerned with payments of kickbacks since they can distort medical decision making, increase costs, and result in unfair competition against other providers. So, what is a kickback? It's asking for or receiving any form of payment referred to as remuneration. I always have trouble with that word. In exchange for referrals of Medicare and Medicaid patients would be considered a crime under the anti-kickback statute. Okay, so essentially, this statute prohibits anyone from knowingly and willfully offering or receiving a form of payment in return for referring a patient to another provider for services or items. It could be anything of value: cash, rent, gifts. There are some safe harbor permits that the government has put in place that can protect certain arrangements. This is where you'd always want your legal counsel to be involved to make sure that if you are getting in some type of an arrangement, that it does meet a safe harbor. There are significant penalties for kickback crimes. Again, this is just like false claims. They can look at this from both a criminal and a civil perspective. Criminal fines can be up to $25,000 per violation and up to 5-year prison terms for violation. Civil, they can pursue a False Claims Act liability with it. There could be civil monetary penalties. You could be excluded from the program, meaning you can no longer participate with Medicare or Medicaid. They can potentially do civil monetary penalties of $50,000 per violation and up to 3 times the amount of the kickback. So here's a real world example. I love real world examples. This is Advanced Centers for Orthopedic Surgery and Sports Medicine and Maryland Sports Care and Rehab. They agreed to collectively pay the United States just shy of $240,000 to settle a claim that they had violated the federal anti-kickback statute. What the government said, and remember it was a settlement, but what the government said is that from January 2002 to October 2004, Advanced Centers referred patients to Maryland Sports Care and Rehab for PT services and paid a referral fee of $30 per patient up to 150 patients and $36 per patient for every referral that thereafter. At the same time, Maryland Sports Care and Rehab was leasing space at a rate that far exceeded the fair market value for similar spaces. So that was considered a kickback scheme. Okay, the next law we want to look into and talk about a little bit here is Stark. What Stark is used for is prohibiting physician referrals for certain healthcare services when there's a financial relationship with an entity unless an exception applies. So this means essentially that the physician has some type of financial relationship with the healthcare service that they're referring to. So this is all about self-referral because the physician's going to benefit from the referral. It could include ownership. It could include compensation. So here's a little decision tree to kind of help you decide if there is a Stark violation. Question 1, is there a referral by a physician for a designated health service payable by Medicare? Then you move on to, then does the physician have a financial relationship with the entity that's going to furnish that designated health service? If so, does the financial relationship fit into an exception? If not, then there's a violation. So if you answer yes to the first two questions, there could be a violation unless the financial relationship actually fits into an exception. So this is again under the Stark Law where you would want to have legal counsel looking at any type of situations where a physician may have some ownership and what that referral looks like, because you want to make sure that it's going to fit into an exception. If it doesn't fit into an exception, then you need to be very aware of that. So exclusion authority. This is something that the OIG has, and that's again the Office of Inspector General. They have the ability to exclude providers. It could be an individual, it could be a group, from the federal health care programs. When you're excluded, it means you cannot bill for treating patients, and your employer cannot bill for you providing services. So this is very interesting, because what happens when you get excluded is, I'm going to be honest with you, no one's really going to hire you, because it's not like they can even have you working with other people. So there is an exclusion list that the OIG has out there. And so what we need to do as people who employ people, okay, we actually, when you're going through the hiring process, we have to go out to this list to see if you've been excluded from the program. Then, because like we talked about that horrible example where somebody had an issue with their license mid renewal period, we also have to make sure that you don't become excluded. So we actually run all of our therapists and assistants through the exclusion list on a monthly basis, because if we would have a problem and find somebody that does end up getting excluded, again, that's a really large payback to the government, and it also involves you having to self-disclose to the OIG. So it's very time intensive if something like this would happen. The OIG list does exist. The nice thing out there is that there are a lot of software companies that you can have a contract with that will help you run through your employees. And we've used that. We've done that for years now. We use one of those software companies to help us. Essentially, they take our list from our payroll, and that's what gets run through on a monthly basis. Okay. There are many reasons of why you can end up on this exclusion list, and that's something I always want to talk to people a little bit about as well. What you're going to see here is a list of mandatory exclusions, and you can see that it really has a lot to do with crimes, abuse, neglect, healthcare fraud, felonies related to controlled substances. So some pretty, in my book, some pretty major offenses that you would be convicted of can get you on an exclusion. So it's not just something you maybe do in your physical therapy practice. Then there's a lot of what's considered permissive exclusions, okay? This can be misdemeanors. This could be having a conviction that isn't even related to anything to do with a healthcare program. That, you could end up on these lists. Failure to pay back student loans. If you've had a health education loan or scholarship obligation and somebody defaults on that, they could end up on the excluded list. There was a case of somebody that I know, another company, that one of their employees apparently had some issue with paying taxes and ended up getting excluded because of that. So this is a very, very big deal and something we take very seriously, and that's something why we audit it pretty regularly. So let's shift gears a little bit away from some of those big federal laws, and let's start talking about relationships. So what is the physical therapy relationship with our payers? Well, we need to look at that from coding, billing, documentation, and enrollments. Okay. So from a coding and billing perspective, we have to submit claims that contain accurate information. We've been drilling that home all semester, right? Examples of improper coding and billing would be billing for services not provided, billing for services that are not medically necessary, billing for services by personnel who are not properly supervised, okay? So think about some of the stories I've told you this semester. The clinician that decided it was okay to go and take a 2.5 hour nap in her car, and then wrote down her billing like she had seen all of her patients individually, when you know she actually wasn't even in the building for that amount of time to be able to have done that. That's a big issue here. Okay. That's something that we had to issue an overpayment on. Actually, I think on that one we caught it before we'd even billed it, so we were able to just do billing corrections. But here too, billing for services of personnel who are not properly supervised. So we had a recent incident where a assistant continued care beyond what a plan of care had been set as. So essentially, the 4 weeks on the first initial care plan of care had passed. Those 4 weeks were done. The assistant continued to treat that person. That's another one where we, now had an issue that we had to issue an overpayment. What is our relationship as far as documentation? Remember, again, you've heard this, I know, over and over this semester, but we need to document to support the claim. Examples of documentation issues: that missing or incomplete plan of care, missing the physician certification, missing documentation of time to support the units of your timed codes, or your documentation simply doesn't support medical necessity. Enrollment, and this is going to be specifically to private practice. In private practice, physical therapists actually have to individually enroll with Medicare to be a provider. Then they can have physical therapy assistants work with them, but you're actually working under that physical therapist number. The billing to Medicare goes in under that physical therapist number. The federal government, probably 6-7 years ago, identified provider types that were more at risk, and private practice PTs are on that list. And what that means is every so often they have to actually go through like this revalidation process with Medicare, so that they know it really is a true and valid provider. Let's switch over to our relationships with referral sources. So let's start talking about rental space, medical directors, and gifts. So this comes back to those kickbacks a little bit, okay? If a healthcare business offers something for free or below fair market value, or offers cash in exchange for referrals, ask yourself the following questions. Am I getting paid by a company for very little work? Do they actually need my expertise? Does the amount of money I'm being paid and offered seem appropriate for the services I'm going to provide? Am I being asked to refer patients to that particular company? So just some questions you can ask yourself. It's kind of that, does this feel good, or does it feel a little fishy, feel a little funny, okay? When it comes to rental of office space from physicians, we cannot pay more for more space than is necessary, and we have to make sure that we're paying fair market value. So we can't mark something up and say, oh, I'll give you this amount of money. We have to really do a fair market value search to make sure that what we're paying for that lease space, and that lease space has to be the appropriate size, is appropriate, so that it isn't a potential kickback. In some types of therapy settings, we actually have medical directors. And as far as medical directors, when we are engaging them in a contract, we have to actively oversee clinical care. And they have to actually be overseeing clinical care and be involved. There's a reason we need them. There's a reason we have a contract. We have to make sure that when we are paying those medical directors, it's again at a fair market value. And they should be spending the appropriate time providing those services, so that the amount of compensation is fair and appropriate. Then we can move to gifts to physicians. Here you're going to analyze this on a case-by-case basis, because it could be considered an inducement to refer. So, for example, are you going in and providing lunch, and at the same time that you're doing lunch, you are doing, for example, education to the physician and the physician staff about a new treatment or something you could do for those patients. That would be looked at very differently. Let's move on to relationships with patients from a perspective of gifts, waiver of coinsurance, collecting cash from Medicare beneficiaries. Okay, relationships with patients. Some of this is going to sound familiar from when we talked about this, when we talked about pro bono services. Federal laws generally prohibit gifts to Medicare and Medicaid beneficiaries. If you would provide a gift, it's seen as inducing a patient to come to your practice instead of choosing another practice. Inexpensive gifts are allowed if there's no cash or cash equivalents, and the value is no more than $10 for an individual, $50 in aggregate for the year. So you can give little things like a pen, or you'll see some clinics that they have like little graduation gifts when somebody finishes therapy. They maybe get a t-shirt or something like that. So low nominal cost things are allowed. Okay. This is what you're going to remember from when we talked about pro bono. So here it is again. We cannot provide free service or waive coinsurance and deductibles. Okay. Remember, every clinic, every setting has to have a financial hardship policy, and you have to stick to that financial hardship policy. If someone can prove a financial hardship, you may be able to waive that coinsurance or that deductible, but they would have to meet the guidelines that you have set. Let's talk about exceptions to those discounts or waivers. Again, this is going to sound a little bit repetitive from pro bono, but it never hurts to hear it more than once. You cannot advertise discounts or waivers of copays. Okay, you cannot routinely waive copays. We have to make efforts to collect the copays and deductibles. Okay, if we can show that we didn't advertise, we don't routinely waive, and we have tried over and over to collect a copay deductible, sent somebody to collections, eventually you may be able to write that off as bad debt, but you have to go through all the steps. Remember, you may be able to waive something due to a financial hardship, but you have to have the policy. The OIG HHS, which is Office of Inspector General in Health and Human Services, did issue a letter several years ago about uninsured and underinsured, that making discounts available for them is acceptable. But again, you have to have a policy, and you have to be consistent in how you apply that policy. As far as collecting cash from Medicare beneficiaries, remember, if they're on Medicare, we have to bill Medicare, okay? So we cannot collect cash for services that Medicare would cover. We can't say, oh, I just don't want to deal with Medicare, so I'm just going to do a cash-based service here, okay? If Medicare covers it, we have to bill Medicare. If there's something that we're offering in our setting, in our clinic, that Medicare doesn't cover, such as wellness or prevention, we can do some cash-based care there, because it's not something that Medicare would normally cover. Some of the typical issues that we see in compliance, this is as reported by the Medicare administrative contractors when they do reviews. Billing for services that weren't documented, billing for services where the documentation didn't support the medical necessity, unbundling, meaning it should all be under one code, but someone bills it as more than one code. Example here would be with some of the wound care codes. There's many things that are bundled into that code. Whirlpool would be one that would be bundled in with some debridement. If I tried to unbundle that and bill that separately, that would be a problem. Upcoding. Okay, so maybe I have several different levels of codes, and I pick something that's a little bit higher level. We don't have a lot of leveled codes in therapy. We've got them now for the evaluations, which is just new this year. But one of the examples I see often is it's really unattended e-stim, and people tend to bill the attended e-stim code. Do I think they're doing it with intent? No. It's something that we just have to continue to educate on, and educate on. But the fact is that attended e-stim code does pay a little bit more, so it could be perceived as upcoding. billing for more timed units than is supported in the documentation. So that's, somebody that's not being attentive to their 8-minute rule. And this is something that you guys, I know we always talk about the dangers of our electronic systems. You always want to make sure that your electronic system isn't maybe allowing something to happen, making sure all the security rules and everything that your system administrator is setting in the background are catching things like this, okay? That's very, very important. Because sometimes it's amazing when we'll talk to some clinicians and we'll say, well, why do you do that? And they'll say, well, and we use a system called Optima. Well, Optima said I could, or why didn't you do something? Well, Optima wouldn't let me. So it's really kind of makes me chuckle a little bit about how much authority they give their software system. Well, when they're really the end user and they need to know. As I said, it may be that documentation doesn't support medical necessity. Simply writing that someone was on the bike for 30 minutes, that doesn't tell me why they needed it or what I was doing was skilled. Knowingly presenting false information. We talked about this quite a bit when we went through our CPT codes this semester. Billing hands-free ultrasound as 97035 when that code specifically says in the definition that you have to be in direct contact one-on-one with the patient during an ultrasound. Billing for aquatic therapy as therapeutic exercise because aquatic wasn't covered. Knowing iontophoresis isn't covered and billing it as simple e-stim, okay? Billing somebody as individual when what you really did was group, okay? Other compliance issues, lack of certification. We talked about that with that poor Illinois provider, right? Major penalties there for something so simple. Billing for services provided by non-qualified personnel. We've talked about that, about the use of techs and aides. We've talked about where the Medicare stance is that, as well as what your State Practice Act says. You really need to know both, and you need to make sure that you're following the most restrictive. Double billing for co-treatment could be an issue. We've talked about this now with pro bono as well as in today's presentation, routinely waiving copays and deductibles. That is a compliance issue if that's happening. Failure to properly use ABNs. And what I'll tell you, where I see the most failure is you get clinics that want to automatically have people sign ABNs, and that's not appropriate. You should only be giving an ABN when you think Medicare is not going to cover anymore, and you're having that discussion with a patient of what they want to do. So you should not be putting an ABN in a welcome packet with the rest of their intake forms and getting blanket signatures on something like that. Compliance issues in therapy, care below the standard of care. Okay, so that would be part of what we saw in that Extendicare corporate integrity agreement and financial settlement. There were issues that was more on the nursing side than it was on therapy, but they just said, you know what, this was a low quality of care. This was such a low quality of care, you should not have even billed the government for that. Okay. Inadequate resolution of overpayments. Talked about that today, right? Once you've identified that you have an issue, that clock starts ticking once you can say you've identified it, and you need to do what you need to do to resolve it, and you need to resolve that within 60 days. Accepting or offering kickbacks, misuse of your provider ID, and duplicate billing. So as a safeguard, one of the smartest things a company can do is put a compliance program in place. Okay, there is federal guidance in what a compliance program should look like. We've got that in our federal sentencing guidelines. It says you need to have standards and procedures. What that means is they're going to look for policies and procedures as to how your compliance program works. You need to have oversight of the program. What they are going to look for is that you have someone in place as that compliance officer that is very autonomous and truly can provide oversight of the program. They don't want it to be a CFO who has financial, impact with the company. They don't want you reporting to your internal legal counsel. Does the compliance officer work with legal counsel? Yep, they're going to probably work together on some things, but your legal counsel internally really is there to safeguard the company in a very different way, okay? When they talk about oversight of a program, they want an autonomous compliance officer, and they want to see the reporting structure that person reports directly to the CEO of the company or to the board of directors, okay? and that person has enough, that's truly that's their role in the company, or it is the percentage of the time that they spend in compliance and doing that job is sufficient for what they need to do. They expect to see training and education in compliance, okay? So training on your code of conduct, training on how to report a problem, training on what the investigation procedures are going to be, training on the fact that you also have a non-retaliation policy. So it's an extensive training on what the expectations are for conduct, as well as if you think you have a problem, what do you do? As part of the compliance program, auditing and monitoring, to me, this is probably the most important component. This is where you're being very proactive as a provider, and you've got a compliance team that is in the documentation, is in the billing. They are looking for potential problems and making sure things get corrected if you can correct it. If it's already been billed, making sure you're doing an overpayment if need be, identifying additional training needs that may come out, or needs for other policies. For with auditing and monitoring, you may go, wow, we didn't really think we ever needed to write that down in a policy. Same thing after an investigation. Wow, we never thought someone would do that. But hey, guess what? It happened. Didn't think we had to write it down that you shouldn't have done it. But sometimes, again, hindsight's 2020. They're going to look for that component of reporting. How do your employees have the ability to report a concern? Okay. They will look to see that you actually have an anonymous option, okay? Because not everybody's going to be comfortable coming forward. So that anonymous option is important. They're going to look at the component of enforcement and discipline, response and prevention. Those all sort of meld together. So you get an investigation. How do you respond? Could it have been prevented? Once you have a substantiated issue, how are you dealing with it? What is the enforcement and discipline? So, for example, with us, we have several people on the compliance team that report to me. And so in order to make sure that we're all dealing with things the exact same way, we talk back and forth, but we actually have a discipline grid. So we have a grid that says if clinician A does such and such, this is the disciplinary action, so that we can make sure that we are very, very consistent, because we can't maybe do a final warning for this person over here, and over here, same absolute problem, substantiated problem, and here we made a decision to terminate. So it's very important that we are very, very consistent in the enforcement and the discipline. If you think there's a problem, what do you do? Well, we always tell people chain of command, okay? So first, try and contact your manager. If you're not comfortable going to your manager for some reason, if you're in a large enough company, you maybe have a regional or divisional person you can go to. If you're still not comfortable with that, then you always have the option of contacting the compliance department directly. We get a lot of phone calls where people just call us directly, but we also have a hotline. So we have a way that people can also get in contact with us anonymously. What I will tell you about that anonymous option is people need to leave enough detail so that we have the ability to investigate. Sometimes they're really generic and very broad, and so we're kind of fishing and not always sure where to start. So we always ask, at a minimum, what is the site location? If they can give us dates of service, if they can give us specific patient names, that always helps us. Once compliance has been notified, and even if you go to your manager or regional, then typically their next step is to take it to compliance. Compliance usually will start an investigation. If it's substantiated, there are many things that may happen. There could be that overpayment. It could be a simple overpayment to the MAC. It could be something big enough that you actually have to do a self-disclosure to the OIG or the Department of Justice. It may be something that we do a new policy and procedure on. It may be something, this was just really truly a teachable moment. We could just do some education, but we also have the potential of discipline. That could be something we handle internally. It could be as far up as termination, and it could be something that even involves us reporting someone to their state board because it was such a level of misconduct that we think their license needs to be assessed. If you still get nowhere with compliance, there is that option of going to the federal government directly and going to the OIG's 1-800 number for compliance concerns. We do really recommend that you try and keep it internally, though, and give your company a chance to address the issue. But if there is something that you feel like you've done it over and over and over and just feel like you're getting nowhere, the OIG does provide that number.